Ladies and gentlemen, today we will be discussing the topic of contact management in tuberculosis within the formal setting of tuberculosis control and prevention. Our previous topic was on TB screening and care cascade. Let's look at contact. Who is a contact? A contact refers to any individual who has been exposed to an index case. There are two types of contacts that can be identified. One of them is the household contact, and the other one is the close contact. Household contact is a person who shared the same enclosed living space with the index case for one or more nights, or for frequent or extended periods during the day, within the 3 months prior to the commencement of the current treatment episode. It is important to mention that the definition of household can vary significantly and must be adapted to the local context. The degree of exposure also varies, ranging from sharing the same bed as the index case to living in the same compound but not in the same enclosed space. Who is a close contact? A close contact refers to a person who is not from the same household but shared an enclosed space, such as social gathering, workplaces, or facilities for extended periods during the day, with the index case within the 3 months before the commencement of the current treatment episode. Let's look at contact investigation. Contact investigation is a systematic process aimed at identifying previously undiagnosed cases of tuberculosis among the contacts of an index case. It consists of two components. 1. Contact identification and prioritization. 2. Clinical evaluation. Let's look at contact identification and prioritization. This involves a systematic process to identify contacts who are at an increased risk of developing tuberculosis. This includes conducting an interview with the index case to obtain the names and ages of contacts, creating a line list of all contacts, and assessing their risk of having or developing TB based on the presence of TB signs and symptoms. Yes, guys, I want us to look at the clinical evaluation. On the other hand, clinical evaluation is a systematic process for diagnosing or excluding active TB among contacts who display signs and symptoms of the disease. Guys, the prioritization of contact evaluation should be given to people of all ages with suggestive TB symptoms. In certain situations where a child under the age of 5 years is diagnosed with active tuberculosis disease, or pleural tuberculosis, that is primary TB, is observed in a younger person, a source case investigation, also known as reverse contact investigation, is actually recommended. This investigation aims to identify the source case of recently diagnosed active TB case. Source case investigation focuses on identifying and screening those most likely to have TB disease among the people who spend the most time with the index case, especially that child. Potential sources for index cases that are children are most likely to be found among the adolescents or adults from within the household, including persons living in the home, frequent visitors, and babysitters. Also in school, daycare, carpools or school buses, playgroups, and places of recent travel. Now, guys, It's time to discuss the TB screening and care cascade for contacts, which can be addressed differently based on whether the contact was invited or traced. My people, contact invitation involves the index patient bringing his or her contacts to the hospital for TB screening. Yeah? During this process, the invited contact should undergo the following steps. The steps that I'm going to mention to you. 1. Vital signs should be recorded, paying particular attention to signs of fever. Fever is a sign of tuberculosis. TB symptomatic screening should be conducted. The cardinal signs and symptoms of TB including cough of any duration, unintended weight loss, drenching night sweats, hotness of the body, chest pain, BMI less than 18.5, and Z-score less than or equal to -2. For children, additional considerations should be made, such as a history of frequent respiratory infection, failure to thrive, reduced playfulness, lethargy, irritability, and contact with a known TB case. The other one is that the clinician should perform a detailed history, taking an physical examination to determine presumptive TB cases, which should then be documented in the presumptive TB register, followed by the generation of a sputum request form. Presumptive TB cases should be sent to the laboratory or designated area for the collection of samples. Afterwards, the patient should be advised on how to collect the results and should be exited through normal facility procedures. In some facilities, clinicians may be educated on sample collection procedures and a designated cough area can be identified to minimize laboratory workload. Patients who are confirmed TB positive from the laboratory should be traced and initiated on treatment. Meanwhile, those who receive negative laboratory confirmation should be closely followed up. And if symptoms persist, further investigation should be conducted to establish a clinical diagnosis. Yes, we all know what clinical diagnosis means. Contacts who screen negative for all symptoms and are eligible for TPT or preventive therapy should be initiated on TPT. Otherwise, they are discharged in accordance with hospital policies and advised to come for follow-up TB screening every 6 months. My people, in the event that an index case fails to bring his or her contact to the hospital for TB screening, contact tracing is initiated immediately. The CHP or community health provider is provided with a list of all contacts from the community to trace. Hope that is what we always do. But then we should always use the community health providers. For all traced contacts, the following steps should be taken. 1. Vital signs should be recorded with specific attention, given actually to the fever. TB symptomatic screening should be conducted considering the cardinal signs and symptoms of tuberculosis. Detailed history taking and physical examination should be performed by the clinician to determine true presumptive TB case. or not. These cases should then be documented in the presumptive TB register, and a sputum request form should be generated. Presumptive TB cases should be sent to the laboratory or designated area for the collection of samples, similar to the contact invitation process. Patients should be advised on result collection procedures and should exit through normal facility procedures. In some facilities, clinicians can be educated on sample collection procedures, and designated cough areas can be established to alleviate the laboratory workload. Yes, people, you hear me? Look here. For those patients who are confirmed TB positive, actually from the laboratory, these patients should be traced and initiated on treatment. Those who receive negative laboratory confirmation should be closely followed up. And if symptoms persist, each investigation needs to be conducted to confirm clinical diagnosis. Contacts who screen negative for all symptoms and are eligible for preventive therapy should be initiated on TPT, or tuberculosis preventive therapy. Discharge procedures should be followed for those who do not meet the criteria, in line with the hospital policies. They should be advised to come for follow-up TB screening every 6 months. My people, my colleagues, we said proper recording and reporting are crucial to monitor the yield of contact investigation and curtail the transmission of tuberculosis. Effective contact management requires the use of the following tools for documentation. Yes, we need to know about the tools of documentation. The first tool is TPT register, TPT stroke contact management register. This register should be used during enrollment of an index case to enlist all their house contacts and close contacts. These close contacts will be within the household, work, and social cycles. Furthermore, the screening status of these contacts should be documented in the same register. We also have contact tracing log. This log should be used to document the tracing of patients in the community, including both phone and home tracing. The data flow for contact investigation proceeds as follows. 1. Identify index cases during the initiation of TB treatment. 2. List the contacts of the index cases in the TPT contact management register. Invite and screen contacts for TB at the health facility under the guidance of the healthcare worker. In case their contacts do not respond to the initial invitation, the healthcare worker at the clinic provides the community health promoter with a list of non-responders. The CHP uses the TB screening community contact tracing form to screen contacts of the index cases and refer those with TB symptoms to the healthcare facility. Contacts less than 5 years old, people living with HIV, and contacts of MDR and XDR tuberculosis. Patients should be referred using. The CHP uses the TB screening community contact tracing form to screen contacts of the index cases and refer those with TB symptoms to the healthcare facility. Contacts less than 5 years old, people living with HIV, and contacts of MDR and XR-TB patients should be referred using community referral form, that is MOH 100. The CHP then returns the form to the healthcare facility, with each form representing an index patient and their contacts. You get it? Hope you get it right. The healthcare worker verifies the forms, updates the contact management, TPT register, and begins investigations for those who are presumptive TB cases. Healthcare workers should do that following the guidelines of the TB diagnostic algorithm. It is worth noting that all households and close contacts should be counseled and tested for HIV. To ensure effective performance and progress in contact management, monitoring should be conducted both internally and externally. Monitoring is very important, my people. Internal monitoring entails reviewing performance against targets during the monthly meetings, while periodic county and sub-county supervisions should assess key indicators related to contact management. These monitoring activities provide an opportunity for continuous mentorship and sensitization. Yes, hope we are together. And guys, thank you so much for your attention. And remember to like, subscribe, and share my channel at Nandi Empress. Welcome back another time. Thank you.